Okay, welcome everyone to Wednesday Morning Rounds. We're going to get started. It's my pleasure today to introduce Dr. Scott Millington. I've known Scott, well, we figured out this morning, for 20 years, so there you go. So Scott is an intensivist at the Ottawa Hospital and an associate professor of medicine at the University of Ottawa. He leads the ICU point of care ultrasound program. He teaches ultrasound around the world and has published on ultrasound related topics with a focus on knowledge translation. He is also greatly involved in the EPIC world. So since the initial phase of vendor selection and going live in the ICU, he since then has built and launched the ICU Virtual Critical Care program, which started in 2023. Which is an EPIC-based program to bring ICU consultation services to 13 partner hospitals in Eastern Ontario. So he's going to talk to us today about his program. Thanks so much for joining us today.
All right. Well, thank you for the very kind introduction. It's a real pleasure to be here. And hopefully you guys can see the screen all right here. I guess if I can see it, you can see it. And yeah, thanks. So I'm Scott Millington. It's really nice to be here. And wait, how do I advance my slides? You can do it with the mouse. Okay, so I had this whole shtick worked out, mainly for Bernie. So I was going to, I'm a POCUS guy. I'm coming to a hostile environment. Cardiology hates POCUS. And I was going to wear something like protective gear. This was the joke, right? And I had this big long shtick worked out. But then I was like, oh, I don't have any gear. I have to go buy it. And I want to ride my bike to work. So I thought, okay, well, what do people do today in 2024 when they're lazy and they want something done for them? AI, right? So I turned to AI and I said, okay, AI, I'm going to give a talk. I'm a doctor. I'm going to give a talk in a very hostile environment. How should I dress? So, okay, here's what we got. Okay. This one's pretty good. Pretty good. I thought, like, the stethoscope over the armor is pretty appropriate, I thought. Good hair too. He's got like my COVID era hair. Okay, here's the next one. This one's good. I like this guy. He's got really pretty eyes, I thought. I don't know why he's holding a paintbrush, though. That one, like, couldn't quite figure out why they put a paintbrush in his hand. But anyway, I like this one. I don't know what he's looking at either. Okay, then take number 3. This one's pretty good. I don't think this would deflect the rotten tomatoes that I'm 80% sure Bernie has hidden away somewhere to throw at me. I do like the bees on the lapel. That's cute. And then the last one, I'm not going to do this forever. I have like hundreds of these. I'm not going to do this forever. This one's probably my favorite one. So this is what I settled on as appropriate gear. So yeah, that was my shtick, and AI solved all my problems. So when I come and give talks, there's usually kind of 2 things I talk about: death and making you feel all sad and stuff. But we won't talk about that today. We'll pick a happier topic. Point of care ultrasound. So we've already kind of done this shtick already. Actually, I was thinking that the last time I spoke here was almost exactly 10 years ago. And I was here to talk a little bit about the POCUS program at TOH and things like that. And so switching to a more serious note, every time I talk to a cardiology audience in Ottawa, I always say thank you. When I started up 15 years ago, it was really the height of the POCUS wars. In many centers around the world, there was just intense conflict around this issue, and that did not happen here in Ottawa, which I've always really appreciated from colleagues in cardiology and colleagues in radiology. We had a wonderful relationship. Obviously there's little bumps in the road, but everybody was great at playing along and sharing, and I think it's been a really mutually beneficial relationship. I've always offered the deal, which I think is a good deal, that we can show you guys something about lung ultrasound and vascular ultrasound, and you guys can show us something about cardiac ultrasound, and it's to the benefit of ICU patients, CCU patients, everybody. So anyway, a sincere thank you for 10 or 15 years or whatever it's been of really nice cooperation between POCUS providers in ICU and ED and the dear cardiology community. So that's been really nice. But we're not going to talk about that today. We're going to talk about virtual critical care. So VCC, or virtual critical care, is something that I'm here to offer to you guys. I want you to steal it. I know you're already in the process of stealing it, and I think that that's wonderful. So let's enhance the stealing as best as we can. So I don't have any disclosures. I don't have any conflict of interest. I got a text from my 13-year-old daughter who's in charge of her brothers saying things seem to be okay. So we're all ready to roll here. So what's the problem? So the problem is we're going to go back to the year 2020, and the heroes of the story, Dr. Neil Povitz, you see there on the left side of the screen. Some of you will recognize your humble narrator here on the right, and we're faced with this virus. And we are getting overwhelmed. So let's put us into like wave 3, if you guys remember. And the problem is that we are getting, here's a map of what used to be called the Champlain Lynn. Linns don't exist anymore, but you guys will remember this. This is kind of like the eastern part of Eastern Ontario. And these are the 13 hospitals that refer patients into the Ottawa Hospital. Now, I've taken our friends at the Montfort and the Queensway off the map here. I've obviously taken the Ottawa Hospital off the map. These are the other 13 hospitals in the Champlain Lynn that like neatly and cleanly refer us patients. And it's wave 3 of COVID, and we're getting a lot of calls. We're getting a lot of calls. We're getting calls about COVID positive patients. We're getting calls about patients on escalating doses of oxygen, and we've got to make some kind of triage decisions about who to bring in to TOH. And so we feel that we are going to be overwhelmed. Like we are going to be getting dozens of calls from dozens of hospitals. And the way we have this set up currently in this era was that the person receiving those calls is the person who's on call in the ICU. Okay, so I'm trying to round on 15 critically ill patients. Actually, at that time, we were at 150% capacity. So I'm trying to round on like 20 or 25 critically ill patients. You know, we're overflowing into PACU and things like that. And meanwhile, I'm getting all these calls from these peripheral hospitals, and I'm trying to squeeze them in between bedsides, and I'm doing a really bad job. I'm trying to get off the phone as quickly as possible so I can get back to my patients, and I'm torn in multiple directions, and I feel like I'm doing a bad job on both ends of those two directions, right? So it's a really unpleasant position to be in. I'm guessing that this feels familiar to some people in the audience, perhaps. And so it's a problem. So on a Friday afternoon, at the height of the third wave, I hopped online. I found on the Ministry of Health, there's a subdivision of Ministry of Health called Critical Care Services Ontario, which kind of manages critical care for the province. And they've got this application program where you can apply for money. And so on a Friday afternoon at the height of COVID, I fired in this like quick application. And I thought, wouldn't it be cool to have a triage service, a group of people who could just deal with this map and then get that off the plate of the people who are in the ICU? And wouldn't that be awesome? And so I waited around. I expected, like, surely by Monday they'll get back to me, right? And of course, I didn't hear anything on Monday or Tuesday or that week or that month. And the third wave came and went, and we didn't get overwhelmed to the degree that we feared. We were imagining like a New York or an Italian kind of scenario that thankfully didn't come. So I just kind of left it at that. And then about 2 years ago, I heard back. So this was once COVID had kind of was receding nicely, and I heard back, and the ministry thought that this was a great idea and that they would fund it. And so that's where we ended up. So the proposed solution that we put forth to the COVID problem, but frankly, it's still very relevant to our day-to-day life today. We still service that map, obviously in lesser COVID times, and we still get criticals from all those hospitals. We still get consultations from all those hospitals, errant phone calls. And the way we had the system working prior to this was, again, it was the on-call ICU doctor who had to interrupt their daily workflow and deal with these calls. So the solution to that, to the COVID problem, and the sort of lesser version of that problem, was what we called virtual critical care. So this is a ministry-funded program that we launched, and I'll go into the dates in a second. And it's basically, there's 3 parts to it. So we asked that there be a program coordinator. So this could be anyone. The person that we chose to run the program actually is an experienced ICU nurse. And we figured that that nurse, she could learn the administrative side of the job easier than an administrator could learn the medicine. And that actually, I think, was a good decision. So Melanie was our program coordinator as we built and launched the program. There's a modest stipend for the on-call ICU physician. And so there was some communication with my colleagues, and our group decided to take this on as a program and to build a sort of parallel call schedule. And we'll talk a little bit more about that in detail. And then the heart of the program is the VCC nurse. And so we were funded to have a 24/7 nurse to actually take the calls and to triage them. And so that person, that ends up being about 5 full-time equivalent nurses. And rather than just hire 5 nurses to manage this program in isolation, what we decided to do, which was really, again, another sort of fortuitous good decision, was we just expanded the entire pool of ICU nurses by 5 FTEs. And then we already have a subset of ICU nurses who run the RACE program, which I'm sure you guys are familiar. We were able to expand the RACE sub-universe of ICU nurses by 5. And then we just said everybody who does RACE can also do VCC. And so that way there's a big pool of nurses who can kind of take these calls. And I'll talk a little bit about the benefits of the program, but that's been really nice for the ICU nurses as well, right? To have different jobs that they can do on different days, just like we like having, different jobs on different days. So that's the bare bones of the program. It's 3 things that we asked for and that we built. And so this was our solution. This is virtual critical care. The goal of the program, pretty straightforward. We wanted it to be good for patients. We hoped that early and easy access to critical care consults would be good for patients. We hope that it would be good for hospitals. If any of you have been out to these hospitals, these are small facilities. These are facilities that have had difficulties post-COVID in terms of staffing, lots of new junior staff. And so offering support, offering resources, offering education to these smaller hospitals has been super beneficial. And we hope that continues. And then there's a view that this hopefully will be good for the region. And that's really about just flow, right? So we'll talk a little bit about the kinds of calls that we've been getting, but there are patients that you want to get to TOH earlier, right? And that's good. There are patients that don't actually need to come to TOH, and it's really good to keep them closer to home hospital. And it's obviously good for the state of, the TOH census to keep unnecessary transfers in peripheral hospitals, right? So that's the goals of the program. There was a big publicity tour. So Melanie's the program coordinator. Melanie and I drove around Eastern Ontario a couple times. We stopped at all the chip wagons. If you guys need a recommendation, let me know. We got lots of ice cream. We went to all those hospitals on that map. We met with chiefs of staff and nurse leaders and administrators, and we promoted the program. We have posters. This was our sort of original poster. There's some things of note. We set out on this exercise of like call criteria. The RACE poster, if you guys remember the old-fashioned RACE poster, it says if your patient's heart rate is less than 90, call us, or not less than 90, less than 50, call us, or greater than 104. We quickly got out of that. We didn't want calls for every heart rate less than 50 in all of Eastern Ontario, right? So we kind of boiled it down after lots of consultation to just, are you worried, right? You're somebody who's in a small hospital. A lot of these folks are family docs who are doing shifts in the emerge, or who are kind of fulfilling a hospitalist role, or maybe a GP anesthesia type role. If you've got a patient that's worried and a second opinion would be helpful, we're here for you. We left it kind of vague at that, and that's actually really worked out well. People have taken that, used that really responsibly. We're offering 24-hour service. We're offering easy connection through telephone or video. And then we gave some example reasons to consider calling here. So you can see for physicians, things like, are you worried about your patient? Are they in shock? Do you need help with goals of care? Would you like to transfer them and you want some help stabilizing them for transfer? Do you have a machine beeping at you and you need some help with the beeps, like ventilators, BiPAP machines? We can help you with all that. Importantly, and I think this is an exciting element of the program, is we're also offering nurse peer support. So as much as there are junior doctors out in the community in uncomfortable situations, there are also junior nurses out in uncomfortable situations. And if they're being asked to do something that they're not perfectly comfortable with, wouldn't it be really nice to be able to pick up the phone, immediately connect with an ICU nurse with 10 years of experience or more, and just say like, hey, they asked me to put this patient on amiodarone. Like, I've got the manual out here. I think I'm doing it right, but can I just double check my work before I put this in the patient? And that's been great too. So we're offering nurse peer support. And so again, if they're worried about an unstable patient, if they're being asked to do something that's not in their wheelhouse, we're there. We've brought RTs to the phone. We've brought dietitians to the phone with issues about a PEG. We've offered social work support, all kinds of stuff that we can resource at TOH that these smaller hospitals don't have. Everybody loves a good flow chart. So there'll be a test at the end. So like, just out of very quick curiosity, if you're wondering how we work the flow here, this is the top part of the flow chart, basically how the calls come in. So the gray box at the top there, you're a doctor or a nurse at a referring hospital, you want an ICU opinion. So the option one is just the good old tried and true thing that we've always done, which is pick up the phone and call critical. So we have not. Oops. It's a patient on base. These nurses, they're used to. Patient probably needs to be. If we want to go to video, then we can easily hop over onto video. And so we kind of port the call from a critical over to a VCC call. We hop on the video, and then it kind of bolsters the critical. We use video. We maybe see the patient, stabilize them for transfer. That's pretty neat. The other flow here, the option 2, this is the new flow that we've added, and this is a VCC call. So this is just a direct phone call. So they want an ICU opinion. They're not sure about transfer. It's really more of a second opinion type situation. They pick up the phone, they call VCC, they get the VCC nurse directly. And then maybe they'll say, okay, look, I'm a nurse out here in Deep River. I just have a question for the nurse. They can just handle that. Great. Over the phone, using video, whatever they need. Or if it's a call for kind of more of a doctor-to-doctor consultation, then the VCC nurse just sends a text to the doc on call. I get the text, I hop on the video, we all have a nice video chat, and then we go from there. So the workflow is pretty simple, and it's actually turned out to work pretty well. We were worried about this kind of cross-contamination, like VCC calls that become criticals and criticals that become VCC calls, but actually that's turned out to not be a problem. Like they just want communication, and whether it's over the phone that started with critical or over the video that started with VCC, it honestly doesn't much matter. It's the same two people talking at the end of the day, and it all works out fine. Okay, let's do a demo. Okay, so here we're going to be doing some technically complicated stuff here, so let's see if we can get this to work. I'm going to hop on Teams. I'm going to share my screen. Let's see, we're going to do that. Did it work? Oh man, this is great. Okay, so first thing I'm going to do is I'm going to make a phone call. So I'm now a doc, okay, in let's say Deep River. I'm in Deep River. I need help from VCC. So I'm going to pick up the phone, calling the TOH switchboard right now. Put it close to the mic for those at home. So I'll call the extension. I really hope he picks up. Hi, Mike. It's Dr. Scott here from the Heart Institute. I was hoping to do a VCC call. Is that okay? Okay, so awesome. Let's meet on video. So somehow I've already know that I'm telling you, so what would happen in real life, I'm breaking the third wall here. So what I'm telling you in real life, I would give the patient's health card number and they would give me a password. That's the exchange that's happening right now. I give the health card number, they give me a password. I'm going to hop on Epic. One thing that you should know, actually, Deep River was a bad example. I'm a doctor in a hospital that doesn't even have Epic. So we're going to talk a little bit about Epic, non-Epic in a second. Half of the hospitals that we help are on Epic, half are not on Epic. So I'm at a hospital now that does not have Epic. So I've got a laptop, just like this laptop that I've been given, and I exchange on the phone the patient's health card number for the password to access Epic. Okay, and we'll go into a little more detail of that. And take your time, Mike. So in this non-Epic hospital, I have a laptop. This laptop has access to a very, very stripped down version of Epic called a thin client. This is a version of Epic that has the ability to do nothing except this. So I can't access the larger Epic network. It's got security controls and things that I won't bore you with. But even though I'm not on an Epic site, here I am connecting to Epic through, I'm going to sign in as a virtual critical care user. And when I open the virtual ICU, this is what I get. So again, I am in a hospital that does not have Epic, and I've hopped onto this thing here, which looks a little bit like Epic that you might recognize. And what this is it's actually a thin client. This is a virtual ICU that we created. So this is an ICU that exists only in the cloud, and we can admit and discharge patients from it virtually. So Mike has admitted already my patient. Remember, I gave him the health card number. He hops on Epic. He admits the patient that I'm worried about to the virtual ICU, which you see him here. And then from the non-Epic site, I just open up the chart. And then I've got a button here that says connect to video. In the meantime, Mike has texted the VCC doc today. Now the VCC doc today, luckily, is Dr. Matthew. So here comes Dr. Matthew as well. I know. Okay, wait, I have to share a different screen now. So now I am, okay, so we can see, oh, we don't have the right thing on screen. Hold on, I got to share something different here. I've got to share. Mike, I can hear you. Can you You're not going to be able to hear us, I don't think. Oh, okay, you can hear me. Great. All right, I'm going to share now. This is getting so technically complicated here. I need to go to Teams. I need to go here. No, I need to go here. I need to stop sharing. I'm going to share now. This. There we go. So this is what I see. This is what we see. And here's the gang that we've assembled here, just live in front of you. What a gang we are, right? So that's Mike. Mike, can you wave, Mike? There's Mike. There you go. So that's Mike. So that's Mike, the VCC nurse today. Okay. And then we've got Dr. Matthew, who's the VCC doctor today. We've got handsome Dr. Millington, who's calling in from a small hospital that doesn't even have Epic. And in 10 seconds flat, we've all met on video and we can take care of the patient. Okay, so that's the demo. I can also join, any of us can join from our phones. If you've got the ICU or Canto app, you can join from an iPad. You can do it on a WOW. I'm the doc that's got the patient with me, so I can now pick up my laptop or my phone or whatever I'm using. I can bring it over to the patient's bedside. We can see the patient. I can talk to the patient. I can talk to the family. We do lots of good stuff. So that's the workflow. I'm going to hang up now. Mike, thanks, buddy. Really appreciate your help there. The crowd was blown away. Like you can't imagine the reaction here was just unbelievable. Thanks, buddy. All right, I'm happy that worked. All right, now let's get back to where we were here. Let me get out of this. Let's get back to, okay, hang up. And I can't believe that worked. That was great. Okay, now I gotta I gotta stop sharing my screen. I don't want Epic. Get out of there. Okay, I gotta get on the right Teams thing. Have I kicked myself out here? I think wait, what's on the screen now? No, wait. I have to share from here. Okay. Oh, thank God you've saved me here. Okay, so share. All right. Great. We're back. All right, that worked well. Okay. Everybody's still online, I hope. Somebody will tell me if they're not. Okay, so that's a quick demo. So that's demo time. Let me pick up the presentation here, or what's going on? No, this isn't working here. Hold on. I am not on the big screen here. I've done something wrong. Yeah, that's good. Amazing. Okay. Okay, so there's a demo. So let me just backtrack because I didn't set that up as well as I could have. So of those 13 hospitals, 6 of them are on Epic. So when we do an Epic to Epic call, it's amazing, right? It's super easy. They're on Epic, we're on Epic. All that they do is they call us on the phone like I just called Mike, and then they put in a consult to Virtual Critical Care, which is an order that they know how to put in because it's just like any other order. That patient pops up on our consult roster. We both open the patient's chart and we go to Zoom, right? It's just like when you guys see a patient at home on my chart, same functionality. You can bring in as many people as you want. It works perfectly. When you're doing one of these consults, it's great. On one screen, you've got the video going. On the other screen, you've got Epic open, and you've got the full richness of the Epic chart, right? I can see notes, I can see live vital signs, I can see lab results, I can see radiology, I can see past medical history, I can see the whole fullness of the chart in real time. I can pen orders for them to make suggestions, right? So I don't have to dictate a bunch of orders or suggestions for them. I just pen them up and then they can co-sign them and it goes live. There's an Epic chat functionality that you guys probably hate, but it works really well in this environment because after I hang up on the call, I can start an Epic chat with me, the VCC nurse, their nurse over there, and their doc, and we can have a chat going forward. And so if little problems pop up in the next few hours, oh, the troponin came back. Oh, that's a touchy subject. Okay, so, something else came back. This result came back. What do I do with this? And I can just answer that question over text, and we don't have to reconvene on the video, right? So that's a really nice functionality as well. Epic to Epic is beautiful. For the 7 non-Epic sites, they get the limited functionality that you just saw. So they hack on to a mini version of Epic through a thin client. And then what I can see there is a much more limited view. They're not on Epic, so they're not putting in data into the system. They're not putting vital signs in. They're not putting in lab work. But I still get some experience, right? I can still see their old historical chart. And when you're doing a consult, to be able to pull up like an endocrinology note from 6 months ago that goes through the past medical history, boy, that's really nice, right? You can really get a full story of the patient, and I can chart. So I can write a note after that consultation and it goes into the patient's Epic chart. And then that site can access my note through Connecting Ontario. So the communication is actually really nice too. So there is advantages, even though it is frankly a little bit clunky using the laptop. And there are cases where the doc is understandably in a panic and they would just rather hack things out over the phone. And you know what? That's great too. Okay, I'm going on and on here. So we launched on April 3rd, so just over a year ago, and we decided to launch with a kind of a soft launch where we covered daytime hours. So we worked out a nursing call schedule with these extra nurses that we had. We worked out a physician call schedule dedicated to VCC. This is going to be one of my take-home points. I do think that when you build a program like this, it's important that this actually be a proper program. It's not going to be as big as your other programs, certainly at the start, but I think it's important that the doc and ideally the nurse or whoever you have triaging the calls has dedicated time to do this. You don't want this job to be smushed in between minutes in other jobs. It's really nice to have this job as a dedicated job. And in our workflow, it's worked well. Our ICU docs have non-clinical weeks where they're doing their research or their administrative jobs, and you can take VCC call on those kind of weeks because getting a couple calls a day in between, doing all your other stuff works out really well. And so having this as a dedicated parallel program has worked well. We went to a full 24/7 launch on September 5th. So we've been going for, 7-8 months now. And it's been pretty good. So we've received 350 calls in our first year. So that's like 1.5 calls per 24 hours, roughly, if you map it out. And, on top of that, of course, these are just the VCC calls. On top of that, there's all the crit calls. So we'll be getting 2 or 3 crit calls a day as well. So probably something like 1,000 calls in the first year, all told. And just talking about the subset of VCC calls, of which there were about 350, a third of those came to the Ottawa Hospital, or sometimes we asked the MOFOR or the Queensway, who are fantastic, to help us out by taking some patients, but they came to a larger center. And we were able to keep 2/3 of these calls at home hospital. So if you just think in our sort of inaugural year, getting the workflow set up, pretty good that we were able to keep arguably 200 patients that otherwise would have come to the Ottawa Hospital at home hospital. So that's I think really nice and a pretty good win for us in our first year. We've got some next step mapped out, more cooperation with the Queensway and the MOFOR who've been wonderful. There's been some interest in expanding. We provide consultation services to the eastern third of Nunavut, so Iqaluit and surrounding region, and so extending the VCC umbrella. Once you've got this program, you can extend the umbrella wherever in the world you want, which is kind of neat. Since there's no more Champlain Lynn, should this program eventually cover all of Eastern Ontario, which takes you really right to the edge of the GTA, maybe not, we'll see. We're supporting some surgical patients, which is a neat offshoot of this. Might be relevant for you guys, I'm not sure. But for example, if you have what I call a non-op surgical patient, which doesn't make sense, but what I'm saying is you've got a patient, say, who's got a tiny little subdural hematoma. So it's a neurosurgical patient, but they're not going to have surgery. They're going to be managed conservatively. That patient would traditionally be transferred to TOH because understandably the small hospitals are nervous with a patient like that. But could we keep some of those hospitals at peripheral hospital closer to home, and they have the support of the VCC team available 24/7 if they're worried about that patient? And so can we keep some of those non-operative surgical patients, closer to home, at home hospital, closer to family? Just an intriguing idea. And then PERT. So if you guys are not aware of the PERT program, so that's the pulmonary embolism response team that we've built at TOH. Hillary Megason, bless you. So the PERT program gets on the phone for anyone with a massive or a submassive PE, gets an ICU doc, a thrombosis doc, an interventional radiology doc, and then the doc who's got the patient all on the phone together for a consult. And then we can access things like directed thrombolysis or clot retrieval or fancy new techniques like that. And we're working on extending that PERT program to that whole of the map that I showed you earlier, so that wherever you have your massive or your submassive PE, you can kind of gather those same people to help out that patient. So that's kind of future plans. Lessons learned, I won't bore you to death with this, but like just get something out in the world. It doesn't have to be perfect. Launch it, get that out in the world, and then you can iterate and build it up. And that's what we did, and it's worked out really, really, really well. This has been just such a massive quality of life. Just think selfishly for a sec. Quality of life improvement for the ICU docs, right? So we were getting pulled every which way by these calls. Again, relating myself to you guys, I imagine you guys, let me guess that you guys get a lot of calls for positive troponins or ECG changes or chest pains, and you're maybe having to triage those calls while you're doing another job. If you could just take all of those calls, silo them in one place, that would be not only good for the patients who would get the attention of that team, but for all the other docs, it would be a massive quality of life improvement just to have that taken off your plate. So just FYI, that's definitely been our experience. The flexibility of the VCC nurse. So we're funded with extra nurses. When that nurse is not on a VCC call, then he or she helps out in the unit. And that's been a major quality of life improvement for the nurses, and to have that extra set of hands in the unit to help out with the sick patients or admissions, or help the race team or what have you. That's been value. I think this has been really nice for the ICU nurses. I don't pretend to have always a great sense of nursing morale, and obviously that's been an issue post-COVID, but having something in terms of the career progression and opportunities for the nursing team, I think has been really nice. Our ICU nurses can grow and become race nurses, which is a really cool job with a lot of responsibility. And now they can also become VCC nurses, and it's a different kind of job you do on a different day. It allows you some responsibility and some leadership and some education. And I think that that's a really nice opportunity for our nursing team in terms of career growth and morale. And, I think these are important things to think about as well. Regional cooperation is amazing. And the thing that I've liked the most, that I've heard from some of these small hospitals when I go around all the chip wagons in the hospitals, is you hear that they're using VCC as a retention and recruitment tool already in the first year. So they're hiring brand new nurses, brand new doctors, and they're saying, I know you're nervous. Like these hospitals at night, oftentimes there's one doc and two nurses in the building at night. And that's the only humans, well, healthcare professional humans in the building at night, right? And so these administrators are able to say to them, look, I know you're nervous about this arrangement, but don't worry. If something truly terrible happens, there's this phone number you can call and you get instantly connected to somebody. There's no switchboard, there's no pager, there's no waiting. And that's been a really nice thing to hear from more than one of these small hospitals. So what about you guys? What about you guys? We're here for you guys. This is getting towards the end here. Everything is ready for you, right? So Epic to Epic, it's already ready. You just need a consult roster. That takes 5 minutes to build, right? And you need to hack out the workflow that we hacked out. For the non-Epic sites, they've got the laptops, they've got access to the thin client. You can use our tech, you can use our network, you can use our contacts. It's there for you, right? It's there for you. I love you guys, but I'm also offering it up to everybody, right? It's there for respirology if they want it. It's there for thoracic surgery if they want it. Any specialty that deals with acutely unwell patients could think about a model like this, if they're already getting these calls from these hospitals, to just kind of formalize it up a little bit. Start simple and evolve. I said that already. This is a program about people. So as much as we kind of oohed and awed about the tech demo and stuff, what's really important is to get the right people in place. And I got a slide about that in a second. Funding is nice. Obviously, funding is very nice. Some degree of funding is probably necessary. But again, from the physician point of view, depending on how busy you are, there's billing opportunities as well, right? So the program can be partially funded by billing. The busier you are, the more that's self-sustainable. I would anticipate that if you guys were to snap your fingers and catch up to us in terms of this VCC program, you would instantaneously be way busier than us, right? This program makes much more natural sense for the Heart Institute than it does for the main ICU, just because of the volume of calls I'm imagining that you're already getting. I don't think you guys would have to do much publicity, right? You're already getting these calls, right? You would just be diverting these calls that you're already getting to a different person or group of people, right? So in that way, I certainly don't want to tell you guys how to do your jobs, but there's a certain logic there. I would just always recommend that make it kind of a formal program rather than tagging on, and the formal program could grow over time. I don't know what you're going to call it. VCC. I have VCC. Virtual cardiac care sounds good, but you got to find something different than that, because it's VCC. It get confusing, but I think it's a good idea. Okay, so I understand that it's a priority or of interest for OHI to do follow-up care post-discharge. And we use our VCC program for this use as well. So this might be of interest to you guys as well. When a patient is transferred out of the ICU at TOH to another hospital, the VCC team follows up with that patient. And it just makes sure that the communication to peripheral hospital was smooth. And so it's possible that post-transfer care or post-discharge home care could theoretically be done by this team. It's just throwing it out there. The tech is there. If the people are there, then this is a job that we've given our VCC team, and it could be considered as well. So what do you need for this program? I mean, you need somebody to triage the calls. And so we debated this, who's going to triage the calls? Could it be like a nurse practitioner? Would it be an experienced nurse? Could we have one of our fellows do it? And we settled, as you heard, on using basically the pool of race nurses to triage the calls. We need a physician to oversee the program. Obviously, at the end of the day, it has to be backstopped by an attending physician. And we chose to have a pool of our ICU docs already existing who are doing a non-clinical week to be the ones to backstop this. You could involve this as it grew into a teaching program, and we have ideas of that, of making it a fellow rotation or something like that. So that's a possibility as well. And then you need ideally, you need a coordinator. We felt we needed a coordinator because there was such a big job in terms of launching and publicizing and building this program. That role is a little bit less necessary now that it exists in the world, but nonetheless, we settled on an ICU nurse to fill that role as well. And that's it. Your humble narrator there made it all the way up to the Ottawa Citizen, so making it big. And the feedback, we're obviously collecting data on this. We've got satisfaction surveys and other data points that we're collecting, and hopefully you'll see some articles and some academic work spun out of this in the near future as well. So that's all I had to say. I'm hoping that you guys enjoyed the presentation, and if you have any questions, I'd love to hear them. Oh my God, so many questions.
Wow, we got lots of questions. I'm going to bring the mic over. Dr. Wood, one of the big bosses here, can talk.
Okay, I'm David Burney, the head of the Division of Cardiology. Scott, thanks so much for making the effort. I liked your title, but I'd like, what I really would like to do is steal some of your money rather than just your idea, because, you say that funding is not essential, but I would argue that it is essential. So tell me a little bit about your funding. You talked about you've got full funding for 5 ICU nurses. I know in a private conversation you said that there's a physician stipend, a daily stipend of $2,000 for the folks that are on call, and that's even before you start individual case billing. How sustainable is your funding?
So the funding flows from the Ministry of Health to Critical Care Services Ontario. I don't know if CCSO manages cardiac care as well or not, but anyway, it's an offshoot of the ministry. They've funded us to the tune, again, of about $1.5 million a year to run the program as our program is currently funded. So the program coordinator, that is a 1 FTE, so that's something like $100,000. There is an on-call stipend that mirrors the race stipend. So the physician stipend for staffing race. So it's $75 an hour is the number to bolster. That's more necessary for us because our call volumes are so low. Obviously, you can bill consults for these. I'm always so uncomfortable talking about money. This is why I'm like, but you can. It is a necessary part of the program for sure. So you can bill consults for these calls, but if you're only getting 1 or 2 calls a day, obviously you're not going to have a sustainable revenue to make people want to take this call. So the stipend was felt to be necessary there. Again, arguably, if it was a very busy program, there'd be more revenue in terms of the billings. And then the 5 full-time nurses to staff the program, and all that together makes up about $1.5 million a year. So it's line item funding right now at the Ottawa Hospital. So it's not a pilot program. This is a program. And so we obviously have reporting duties to CCSO and to the Ministry of Health. We're reporting monthly call volumes, patients transferred, patients not transferred. The hope from the ministry's point of view, I don't want to speak for them, of course, is that this program is money saving, right? It only takes a few transfers avoided to save back the amount of money that they're spending in terms of this program. So we're going to be making an argument. We are monthly making an argument that this program is saving money in terms of transfers avoided. And That's the money side of things. So I think funding, yes, is necessary. Whether external funding is necessary, that is situationally dependent. Obviously, everything's easier to run when you have external funding, and how much of this would mirror us kind of depends on your specific situation.
It's just a quick follow-up call. So your money is not time limited. It's in perpetuity as far as you know. And second question is the funding is separate from your race program funding.
Correct. It's separate from the race program. This is a new program, and it is not time limited. Again, I plead complete ignorance as to how money works at the level of the hospital, but the funding people at TOH have said that this is a quote line item funding item for the hospital, meaning that this amount of money is flowing into the hospital every year, and it's not a 3-year or a 5-year pilot program. I anticipate CCSO is obviously following closely and meeting with us quarterly. If this program turns out to be underused, not revenue satisfactory, then I do anticipate the program will be reviewed and the funding would be in danger in that situation. So, there's no formal deadline to this, but we are on the clock in some important way, I'm sure.
Scott, thanks. Great presentation and exciting work. Congratulations on getting the program going. I think we maybe take the finance kind of discussion offline.
Yes.
Because the information that we've gotten from our counterparts is that it was a pool of funding initially, and then it is rolled into the race as this part of that same line item. So we need to clarify that, obviously.
Yeah.
And maybe we take it offline.
Absolutely.
Yeah.
And you should definitely take everything I said about money with a grain of salt, because I'm not a money guy, personally or professionally. So I have a limited understanding of how the money flows.
A couple of other questions. Do you have any data on whether you've impacted outcomes? I have several questions, but
yes,
that's one.
So the data that we're collecting right now, if I can take them one at a time, it'll be better for my brain. But so the data that we're collecting right now, again, we've only been up and running 24/7 for about 7 months. So the limited data that we're collecting now is the sort of raw data, the calls, the number of calls, what happens to these patients. And then we're collecting satisfaction data from the people who call us. We're working on satisfaction data from the actual patients and families as an interesting offshoot to this. And that's where we are right now, with plans to grow the academic side of this in the future.
It seems to me the way the program is structured, that the key element is actually the nursing, and the fact that the physician is removed from their other clinical duties at the time, so they're not they can focus on the CCU or the ward or wherever they are, and not be dealing with the outside calls. So that piece, and then the nursing support. Is that fair?
I think that's a very fair statement. So the heart of this program is definitely the nurses. The nurses are the ones who are taking the calls. If we have follow-ups, so after a call, if we keep the patient at peripheral hospital, we will follow up with them the next day and maybe for a couple days. And so it's the VCC nurse that's arranging all of that, scheduling it and things like that. They're also receiving not a ton, but more and more nurse-to-nurse support calls. So yeah, they're the heart of the program. And then they just reach out to us. They just send us a text when they want us to join a call. So yeah, absolutely the nurse. It doesn't have to be a nurse. This would be a cool role for like a nurse practitioner, a physician assistant, fellow, what you guys would call cardiology resident, but somebody has to staff it. And then in terms of the second part of your question, I personally think that, yeah, having this as a dedicated job has been a huge benefit. I didn't want, as I was launching this program into the world, my colleagues to get a VCC call, to have an anxious isn't the right word, but a worried doc on the other end of the call, a patient sitting there waiting to go on video, and then have my colleague be intubating a patient, right? So having this as a separate dedicated job was important, and that's worked out really well. It's been relatively easy for us, just by the fact that, like I said, most of my colleagues have their life sorted out, that they have non-clinical weeks. Adding this to their non-clinical weeks has been a relatively easy lift. Now, if this program gets more and more busy, then that might have to be reevaluated. But for now, that's how we're working it. The only clinical job that people are doing at one time right now is VCC, and that's been a value. Taking these VCC calls, taking the criticals off the table from the team that's in the ICU has been nice.
So with that in mind, much as we'd like to see your pretty face, how important is the video part for the process?
So, you know, the video is really, really, really nice. So it's really nice on the human element to be able to go doc to doc and just, they see your face, you see yours, you know who you're talking to. It's not just kind of an anonymous voice on the phone. But there's a lot of these calls that we just deal with on the phone for sure, especially at the non-Epic sites, because even though we've made the workflow as easy as possible to hop on video with the laptop, it still involves going to get the laptop. Oh, it's dead. Where's the plug? Plug it in, wait for it to charge up to, 2% so you can boot it up. And, so it's clunky enough that sometimes we just want to deal with it over the phone. And that works fine. I always try to say that this is a program about people, focus on the people. The tech is relatively easy in the background. So what we see is that of the calls that we use video, the vast majority of them come from the Epic sites. And that's just because it's literally one click and you're on video, right? So we're working to make the non-Epic workflow easier. More and more of these hospitals are going to join the Atlas Alliance over the coming years. So this problem will get easier. There's already 1 or 2 queued up to join next year. So we'll be more and more Epic, and that'll be easier. So I like to say video is nice, but not necessary. It also, I know we're not talking about money right now, but it also impacts money because the way that the billing structure is set up right now, today, it's always changing. But the way it's set up now is that if you use video, you can bill a normal consult, whereas if you don't use video, you can bill a much lesser amount. So that's a factor.
Oh, 2 more quick questions.
Hit me with
so the outside person is submitting a consult to the service?
Yes. So in Epic to Epic sites, they put in a consult order, just like you would consult any other service. And then that consult order causes the patient to pop up on our consult roster, probably the same functionality that you use. For the non-Epic sites, it's not electronic in that way. It's a phone call.
So you, last question, I promise. So you've put them on, you've got a service that's dealing with this in the daytime. At night, there is also an on-call team. And is that including are the residents or fellows taking those calls? Is it staff? How's that working?
Not yet. So we have the way we've arranged the call coverage, because the volumes aren't enormous right now. So you might get 1 or 2 VCC calls and then 2 or 3 critical calls on any given day. The way that we've managed it is that you're on call we've taken a week of VCC coverage and cut it in 2. So you're either on call Monday, Tuesday, Wednesday, so 72 hours straight, or you're on call Thursday, Friday, Saturday, Sunday, 96 hours straight. And that's worked out well because we're not getting a ton of middle of the night calls. So you're actually, you get woken up every once in a while, but it's not too bad. And so it's the same team, the same doc, and then the nurses do 12-hour shifts just like their nurses. So this is really a function of how busy the program is. If you're getting calls all through the night and you're up all night, obviously you can't do that. But for us, because we're moderately busy during the day and then we have the odd call at night, so far it's sustainable just to chop a week in half and have the team do that kind of coverage.
We got a couple more questions. Dr. Chan and then Erica.
Of your 300 plus calls, I'd like to know a little bit more detail. How many of them are exclusively, now that's a key word, exclusively addressed by the nurse? And how many are exclusively addressed by other allied services?
Yeah.
Compared to follow-up, the key word is exclusively.
Yeah.
It's not just, we don't want a nurse just to kind of procrastinate or delay the interaction with the MD, right?
Yeah.
So I think that the breakdown of those numbers are critical.
So I'll give you ballparks because I don't have the exact numbers in front of me, but 350 calls, probably 10 of those calls have been for the purposes of an RT specific question, meaning that they've got a BiPAP machine or a ventilator that's beeping at them and they want help troubleshooting it. About 30 of those calls, so let's say 10%, are nurse to nurse calls for help that the nurse deals with exclusively. It's a nursing question. How do I give this? How do I mix this? How do I assess this? And they're dealt with by the nurses. The nurses will just let us know that the call happened the next time they talk to us. And then we'll decide if any follow-up is necessary. that's a piece I'm really trying to grow. I was really hopeful that we will get more nurse-to-nurse support calls. I think because it's a new program, we've had to really socialize the idea of a nurse consulting another nurse. Like, this is something that I think doctors do all the time. We reach out for help, but it's not in the sort of normal state of affairs for a nurse to call another nurse at another institution for help. And so we've done a lot of publicity with posters and meetings and things like that. And we're seeing the volume of these kind of calls slowly build over time. But the nurse to nurse calls have been a small part. It's been, 7-8% of the calls. But I see, maybe I'm being optimistic, I see a trend over time. And as this becomes more normalized, I think in the region, we'll get more of these calls. So that means that 90% of the calls do involve a doc. And that's okay for us anyway.
Erica?
Hi, Scott. Erica, we've spoken before and love your presentation and huge advocate. I just wanted to confirm for my own memory, the race doc does not do VCC at the same time. They're separate.
They're separate.
Separate.
That's right.
Okay.
Yep.
Cool.
Yep.
Thank you. That's all I wanted to check.
Yeah. So we have a separate race team. I mean, life is life. And on the very rare occasion we've had call coverage difficulties and we've had to, deal with awkward situations like that somebody's sick or whatever. And, everybody has double coverage situations and emergencies like that. But in terms of the call schedule building, there's an ICU team, there's a race team, there's the VCC doc, and they're separate and siloed.
Scott, I have 2 questions. One, are you tracking sort of turnaround time? So from the time that somebody places the consult or tries to get call, whatever, to when you actually are speaking with the other physician?
We're not tracking that, but
or do you have a sense of
it's
it?
very fast. So because we're not, so because we're not going through critical, or because we're not going through a pager or switchboard mechanism, it's a direct phone call. They're an instant contact, just like I was in instant contact with Mike. So the first point of contact is instantaneous. And then the time to get the doc on the video, we have set a kind of hope that we can convene on video within 10 minutes as our sort of hope. When you're doing this call for 96 straight hours, you got to live your life, right? I got to go to the grocery store. I got to pick up my kids from school. So I've got these contingency plans. Luckily, the tech is really good. If I go run an errand, I bring my iPad, I bring my phone, so I can actually hop on these calls on both at the same time. I can chat on the phone, video call, and then I can look up stuff on the iPad. So I can park the car. Don't worry, I'm not doing this while I'm driving. I can park the car. I can take these calls remotely, and it works pretty well. You can use the laptop. So anyway, the hope is sort of a 10-minute time frame to hop on the video. I think as this program kind of gets normalized, we'll have to extend that out a little bit. And so I've said to my colleagues, worst case scenario, please be available to come to the phone within 20 minutes. But we're usually much faster than that.
And
That's right.
And one other question. Right now, the program is completely operated, I guess, suppose by attending physicians.
Yeah.
One, do your fellows sort of ever participate as observers or to watch to kind of just for learning? And my second question is, are there plans to extend that to fellows? One of the criticisms that I have heard from the community is that they don't like it when they call our institution and they speak with house staff, that they don't get to directly get to an attending quickly.
Yeah.
So I'm just curious on your experience with that.
Well, it's tough for us because the volumes are relatively low. Again, I'm imagining a world where if you were to do this, your volumes would be much higher. You also have, I think, a higher number of cardiology residents than we do ICU fellows. We have 3 or 4 ICU fellows per year in our program, so we wouldn't have enough to do it consistently. So we've made this attending based, and I agree with the sentiment that it's nice for the peripheral hospitals to get right to the attending, especially because many of these calls that we're getting are about end-of-life decision-making. And it's a bit easier to do that when you've got some gray hair, right? So we're getting a lot of calls to say, look, I think this patient's dying. I just want to make sure I've done everything before they pass. Or This is a category 3 patient with limited goals of care. Can you help me with basic medical care? Or this is patients just dying and I'm uncomfortable. Can you help me with palliative care? Or I don't think this patient should get intubated. Can you help me talk to the family? All these kind of calls are much easier to deal with by attendings rather than sort of have that other filter in. So I think there's an advantage. Could this be a teaching-based service? Absolutely, it could be. It wouldn't work for us right now for those 2 reasons, because we're getting so many calls that directly or indirectly involve end-of-life care decision-making. And because our volumes are low, I don't think it makes that sense for us right now to have learners in the loop. But a busier program that was less about those final decisions could absolutely be a teaching program, I think.
Okay, are there any other questions? Thank you so much. That was great and fostered a lot of discussion. Have a good day, everyone. Next week, Renee Boudreau is going to be talking about the AMI danger trial. So please join us for that.